Cushing syndrome, named after the famous neurosurgeon Harvey Cushing who first described it, is an endocrine disorder with elevated cortisol levels in the blood. In some cases, Cushing syndrome results from a pituitary adenoma making excess ACTH, and in those situations it's called Cushing disease. Normally, the hypothalamus, which is located at the base of the brain, secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH then travels to the pair of adrenal glands, on top of each kidney, where it specifically targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland, and is subdivided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona fasciculata is the middle zone and also the widest zone, and it takes up the majority of the volume of the whole adrenal gland. The ACTH specifically stimulates cells in this zone to secrete cortisol, which belongs to a class of steroids, or lipid-soluble hormones called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein called cortisol-binding globulin, and only about 5% is unbound, or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in the kidneys and dumped into the urine. Free cortisol in the blood is involved in a bunch of stuff, and it's part of the circadian rhythm. Cortisol levels peak in the morning when the body knows we need to get up and go, and then drop at night when we're getting ready for bed. In times of stress, the body needs to have plenty of energy substrates around. So cortisol increases gluconeogenesis, which is the synthesis of new glucose molecules, as well as proteolysis, which is the breakdown of protein, and lipolysis, which is the breakdown of fat. Cortisol also helps to maintain the blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, like epinephrine and norepinephrine, and this narrows the blood vessel lumen. Cortisol also helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, like prostaglandins and interleukins, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear, but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH, respectively. Less CRH also tells the pituitary gland to make less ACTH, so the pituitary gland ends up having 2 reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually cortisol levels go back down to the normal range again. In Cushing syndrome, cortisol levels are constantly higher than normal, so its effects are exaggerated. Excess cortisol leads to severe muscle, bone, and skin breakdown, which are the major protein stores of the body. It also leads to elevated blood glucose levels, and that leads to high insulin levels. Insulin, among its many actions, preferentially targets adipocytes, or fat cells in the center of the body, around the waist and buttocks. In those cells, the insulin activates lipoprotein lipase, which is an enzyme that helps those adipocytes accumulate more fat molecules. The result is central obesity. In addition to this, the high cortisol levels cause hypertension, and this is for 2 reasons. First, they amplify the effect of catecholamines on blood vessels. And second, cortisol starts cross-reacting with mineralocorticoid receptors, which normally only bind a related steroid hormone, mineralocorticoid, which are secreted from the zona glomerulosa layer of the adrenal cortex. In other words, because the cortisol is structurally similar to mineralocorticoid, it can bind to that receptor, and it can trigger the mineralocorticoid effect, which is mainly to increase blood pressure by retaining fluid. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. Excess cortisol also dampens the inflammatory and immune response, making individuals more susceptible to infections. Finally, high levels of cortisol seem to impair normal brain function, but the exact mechanism here is unclear. Cushing syndrome can happen because of exogenous cortisol, meaning that it comes from outside, usually in the form of medications. But it can also happen because of endogenous cortisol, meaning that the excess cortisol is made by the body. The majority of cases of Cushing syndrome happen in individuals using exogenous steroid medications over a long period of time, often to treat autoimmune and inflammatory disorders, like asthma or rheumatoid arthritis. That's because the molecular structure of exogenous steroid medication is so similar to cortisol that they mimic its actions on various tissues. In fact, exogenous steroid medication can also cause negative feedback on the hypothalamus and the pituitary gland. This causes a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause the zona fasciculata to physically shrink or become atrophic. Since that's the widest part of the adrenal cortex, it can have a measurable effect on the overall size of the adrenal gland. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing syndrome to develop. In addition to taking exogenous steroid medications, Cushing syndrome can also result from increased levels of endogenous cortisol. The most common reason for that is excess ACTH. The leading cause of that is a pituitary adenoma, which is a benign tumor of the pituitary gland, and this specific condition is called Cushing disease. The exact reason for the development of this sort of benign tumor isn't known, but unlike a malignant tumor, the cells don't invade neighboring tissues or spread to other parts of the body. Instead, the pituitary adenoma simply grows in size and secretes too much ACTH. The excess ACTH overstimulates the zona fasciculata of both adrenal glands, which grow larger and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, like small cell lung cancer. And in these cases, the excess ACTH is coming from somewhere other than the pituitary. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing both CRH and ACTH production. Although this doesn't have any effect on the zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they've grown independent from any stimulatory signals, the zona fasciculata of the uninvolved normal adrenal gland shrinks and produces less than the standard amount of cortisol. The net result, though, is still abnormally high levels of cortisol, and that causes Cushing syndrome to develop. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol on its various target tissues. Resulting from the increased breakdown of most types of tissue, the individual presents with muscle wasting in thin extremities, skin thinning, easy bruising, and abdominal striae or lines, as well as fractures due to osteoporosis or brittle bones. At the same time, there's fat redistribution. So classic findings include a round, full moon-shaped face, a buffalo hump, which is a fatty hump on the upper back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, excess cortisol causes hyperglycemia, or high blood sugar levels, that can progress to diabetes mellitus, hypertension, or increased blood pressure, along with a high risk for cardiovascular disease, as well as increased vulnerability to infections, poor wound healing, amenorrhea or absent menstrual bleeding, and psychiatric or mental disturbances. Diagnosis of Cushing syndrome is initially based on measuring the free or unbound cortisol in a 24-hour urine sample, in order to assess the total amount of cortisol excreted in the urine over a 24-hour period. Alternatively, blood or saliva tests late at night can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels, but if Cushing syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production, and ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas and carcinomas, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone. Unlike pituitary adenomas, ectopic sites of ACTH productions typically don't respond even to high doses of dexamethasone, and the serum cortisol remains high. After all that, imaging can be used. An MRI of the pituitary gland in the case of Cushing disease, a CT scan of the adrenals when adrenal pathology is suspected, or a CT of the chest, abdomen, or pelvis if there seems to be an ectopic site of ACTH production. Treatment of Cushing syndrome depends on the underlying cause. If it's due to exogenous medications, then the offending drug is gradually decreased and eventually stopped if possible. It's important to avoid sudden steroid withdrawal, though, because that can cause an adrenal crisis, which is life-threatening. That's because the adrenal glands might be atrophied and might need months to recover fully, and during that time, the body needs the exogenous steroids to function normally. If Cushing syndrome is due to a pituitary adenoma, like in Cushing disease, then surgical excision of the adenoma might be needed. Alternatively, medications like adrenal steroid inhibitors, like ketoconazole and metirapone, can be helpful, especially for cases of ectopic ACTH production or adrenal carcinomas that have already spread. Alright, as a quick recap, Cushing syndrome is any condition or situation that causes increased levels of cortisol. It can be exogenous, meaning drug-related, or endogenous, meaning that it's from an adrenal tumor or excess ACTH from a pituitary adenoma, in which case it's called Cushing disease, or from an ectopic site like small cell lung cancer.
Hey guys, thanks so much for watching. So this one was kind of a long one, but hopefully you learned a lot more about Cushing syndrome. Special kudos to Antonia for writing this awesome script, Rishi and Kyle for editing, and Tanner for the voiceover. And I actually did the illustrating and video editing for this one, which was a lot of fun. As always, if you guys love our videos, be sure to share us with your friends on social media. And if you're looking for more studying materials on this topic or any of the topics of our other videos, definitely check us out at osmosis.org. Thanks again, guys. See ya.